Hi everyone, and welcome to this MACP Southwest webinar. My name is Gethin Lynch. I'm the Southwest Regional Representative. The original plan for this talk was going to be a face-to-face chat in a hotel somewhere in the Southwest where we would entice some delegates down to the Southwest beaches, but unfortunately due to COVID, we've had to change tact. However, this has create an opportunity where we've got some nationally recognized speakers tonight, which is excellent. And the topic is around first contact practitioner and advanced clinical practice. We have some excellent speakers that have given up their evening. So without further ado, I'll pass you on to Helen Welch, who is up first, who is the chair of the MACP. Just with regards to the Q&A session, there will be a section at the end, an opportunity for you all to ask questions on the live Facebook feed. And we should hopefully have an interactive discussion towards the end. Helen, over to you.
Thank you, Gethin, and welcome to people watching it on Facebook live tonight. What I thought I would do to start off the evening is to introduce for both members and non-members what the MACP is up to, both strategically, nationally, and also regionally in the area that you work with, and just help set the scene for some of the MACP's involvement in both the FCP and the AP framework that's been led by Health Education England. If I can have the next slide. So for people that don't know what the MACP is, it's a professional network, part of the MACP, but it is for physiotherapists who have reached a professional standard in musculoskeletal physiotherapy. So it's a professional network that you have to pass a membership exam or have done a course leading to membership that gets you a full membership of the MACP. Currently, we have 1,200 full members who pass this stringent examination process. But we also have associate members and now affiliate members that are looking to work towards membership, in the future. Where we sit internationally, we're part of IFONT, and IFONT is the International Federation of Manipulative Physical Therapists, which has 22 member organizations and 16 registered interest groups across the world. And we're a recognized subgroup of the World Conference of Physical Therapy. We have the next slide, Gethin. As part of the work within the MACP on a UK-wide nation, we have established good partnerships with both our high academic courses leading to membership, but also the Charter Society of Physio, ARMA, our academic partners, JOSPT and Elsevier, and also our work with Health Education England and the MSK Physiotherapy Partnership, which is a group of professional networks that have come together, putting patients at the heart of the developments and the care that we provide. Next slide, Gethin. So a little bit about the organisational structure. I took over as chair this year, and I chair a very active executive committee. And underneath that sits some subcommittees and working parties, of which the regional reps are a new development that we wanted to really reach out with our members across the UK to both encourage, inspire, and to disseminate what the work of the MACP executive were doing both nationally and internationally. Next slide. So just to talk a little bit about Gethin's role. So we have regional representatives across the UK, and we're always looking for more MACP members that have an interest in promoting MACP activities in the area to join that group. So as I say, the role is really to promote and support developing MACP activities for members, but also for non-members. What we want to do is grow the MSK physiotherapy skills and knowledge base together, and just be a part of that MSK partnership driving that. So as a group, we aim to run courses in your regional area, webinars like this one, and also networking events that we can put together potential mentors and mentorees, both in terms of knowledge and skills, research, management, leadership, everything that sits underneath the 4 pillars of advanced practice. We also hope that the regional reps, if I go back a little bit, Gethin, the regional reps will basically help guide and shape the organisation for the future. So Gethin sits underneath the executive committee, and he feeds directly into the MAC committee. So your voice will be heard at the executive level and helps influence both our 5-year strategy moving forward. Gethin, next slide, please. Thank you. So what are our achievements to date as an organisation? So recently we've had a review of the membership, and we've had the addition of a new membership category. So we're welcoming affiliate members to the MACP, and these are people physiotherapists that might have an interest in musculoskeletal medicine and want to get involved with some of the work that the MACP is ongoing, and maybe considering looking towards membership in the future. So this is really our undergraduates, our band 5, 6s that are thinking about specialising in MSK and looking for an organisation to help guide them professionally to achieve that. We've got a new website with increased functionality. We've recently reviewed the constitution to make it fit for purpose going forwards. We've got new roles on the MACP Executive Committee to try and reach out with our regional members and engage more with our professional partners. With that, we've seen a rise of membership with our new routes to membership. We've tried to enhance our member benefits. We continue to fund both our affiliates, our associates, and our full members. And we get involved nationally and internationally with running high quality MSK conferences, both with IFONT and with the CSP with Physio UK. Next slide. So currently, in terms of our routes to membership, we have 3 main pathways to gain full membership to the MACP, and some of these might be touched on later on when Neil and Amanda talk about the development of the AP process and ways that you can interact on that development career. So we have our UK-based MSc level courses. So we have a range of courses around the UK, which as part of the MSc, you get MACP membership. We also have reciprocal recognition with our IFONT members internationally. So if somebody does an equivalent course in Australia, they can come over here and gain full MACP membership. And reciprocally, we can go to Australia and get membership of the MPA. We also have a portfolio route, and this is looking at experiential learning with the understanding that not everybody learns in the same way at the same rate and the same route. So looking at a standard and a recently developed accelerated route, looking at, again, working towards full membership. If I have the next slide. So in terms of the MACP, we've really got a global position feeding into IFONT, which actually feeds into WCPT and up to the World Health Organization. So the MACP has been able to influence MSK strategy internationally. And we can see with that with some of the international frameworks that the MACP members have been involved with. Next slide, Gethin. So in terms of IFONT, this is our international governing body. So this is who regulates us from the MACP and who ensures that we are reaching the clinical and academic standards to join this international network of physiotherapists. If I get you onto the next slide. So in terms of our member organisations, of the 22 member organisations internationally, the MACP is the UK member organisation of IFONT. Next slide, Gethin. So in terms of the quality assurance and the quality control of the international standard, all courses that lead to MACP membership have to go through a programme approval process and are subject to external assessor and annual monitoring of the programmes. We then have to submit a 6-year international monitoring process to IFONT to maintain our member organisation status and the status of courses leading to MACP and ultimately IFONT membership. Next slide. So some of the work that may be talked about later on is really when they've looked at development of MSK-AP standards in England, they have used a recognised international standard, an international framework of MSK excellence, and done some mapping work looking at both the AP framework and the FCP framework. But I'll leave that to other people to talk later on in the webinar. Next slide. So in terms of how this might fit in and to set the scene for maybe Amanda and Neil's talk later on, we've got a chain of clinical governance coming down from the World Health Organization through WCPT, through IFONT, and then through the MACP, which might influence and help shape the development of AP MSK standards in England. Next slide. So what I'll do is I'll let the other people in the group that we've been working with in conjunction with Health Education England, both Amanda, Neil and Tim, to talk about the next stages in pathway development, to set the scene of integration both with FCP and AP, and how that sits within the career development of a physiotherapist wanting to specialise in MSK, musculoskeletal physiotherapy going forward. Thank you.
Thanks, Helen. It's interesting to know what the MACP is up to. There we go. Right, we'll the next speaker. And next up, we have Simon Ingram, who is the first contact practitioner clinical lead for Somerset NHS Foundation Trust. Simon's done some wonderful work with a fairly well-established integrated service in Somerset, and he's also been very helpful to our own kind of FCP service in North Devon here. So without further ado, Simon, over to you.
Thanks, Geff, and also thanks to the MACP for obviously the invite to come along and talk about our journey in Somerset today. So firstly, if you can move on, Geff. My name's Simon Ingram, as Geff said. My background is working as an APP across all aspects of the MSK pathway, from primary care, orthopaedic triage, secondary care, which are both primarily in an upper limb bias, and also ED. So I've kind of have a full spectrum of where MSK sits. Today, I'd like to welcome you to Somerset first and foremost. I'm going to talk to you a little bit, albeit virtually, about our journey down in Somerset and how we got to where we are today. So firstly, it started back in 2015, so it's been an ongoing process. Like most MSK services, I think we recognised that we were under increased demand from referrals and also some poor quality, and recognised that in physiotherapy and also in the orthopaedic services meant that there needed to be change. And looking further upstream, one of my colleagues at the time, Amy Peake, a team Amanda's work from up by the lakes, and alongside our physio lead Trish Acton, decided to start a pilot with one of our local GP surgeries where we did 2 sessions. And since then it exponentially grew. They rapidly increased it to 5 sessions, and we saw some other sites start to develop as well. On the back of this, we did a 2-year service evaluation in 2018, which got buy-in from our exec team, that they could start to see the system benefits of this model, but also nationally as well. And it was adopted as one of the case studies in the NHSE mobilisation guide. At a similar time, the other trusts in our county, so our community trust, Somerset Partnership and Yeovil District Hospital, also had some FCP sites up and running, but we all had very different models and kind of working in our own silos. The key turning point, I guess, for us was when we came together as part of an MSK Task and Finish group. With one of the kind of key drivers was to try and develop a pan Somerset FCP provider model, and that brought us all together. From that, we were able to put together what we thought was the best fit for Somerset and the local population, and our exec team, as I say, were fully supportive. In fact, at one point when there was still a 30% offset for the PCNs, I think we were one of the only regions in the country where our acute trust were happy to pay that as a commitment to FCP. Obviously, since the GP contract changed, and that became 100% funded, and obviously with a lot of increase in uptake from the PCNs, and we had a proposed rollout for April, and then there was just a small matter of a pandemic. So at times, I guess it has felt a little bit like this farmer, but I think ultimately we've come together with lots of collaboration, and that's helped us to keep our vision and move forward. You can move on, Geth. So what does our provider model look like? Well, we obviously as an organisation employ the staff, and we provide a service to our PCNs in Somerset. We offer, our offer was one whole time equivalent per PCN. This was based primarily around sustainability, but also equity across the county, but also happened to align with the NHSE guidelines also. It was a 44-week contract, and obviously that's in the process now of being agreed with most of our PCNs. I think one of the other key aspects is how we try to support that implementation. We recognise through test and learn through some other sites that the ones that were really successful were ones that were really, really well embedded in the practice. And we felt this was really vital, and so therefore we really offer that as part of the package. We recognise that sometimes it's those chats over coffees, you know, with GPs that allows that upskilling, so it can be very informal, and we would encourage the FCPs to make sure they attend the huddles and the meetings to enable that to happen. I guess one of the biggest benefits for our patients is that our staff have pathway knowledge, so they work across the pathway. This means that hopefully it means fewer steps, and we can get patients on the right pathway from the start. I guess in terms of the PCNs, the most attractive aspect of our model is the governance. So we would take all responsibility for employment. We also are, as we are providing them with a service, that enables them to avoid any VAT, so is attractive in the financial sense also. In part of that system-wide governance, we developed locally a Somerset MSK capability framework, which was pretty much based upon the two national frameworks that have already been mentioned by Helen. And that enabled our staff to identify training needs and any CPD that we needed to make sure that they were capable to work in primary care. Alongside that, we also provide that clinical supervision and peer support, which we all know is vital, as primary care particularly can be quite isolating at times. Do you want to move on again, please, Gav? So we're fairly simple folk down here in Somerset. We have one CCG. We have now two trusts. So we merge with our community and mental health trust, and then we have Yeovil as another acute trust. We have a population of just over 500,000, and that's now broken down into 13 PCNs. You may be aware that the national guidance for 2021 is to have 50% coverage across your CCG region of a one-time whole equivalent FCP. By next month, we'll have 11.9 whole-time equivalents covering 11 out of our 13 PCNs. So well on track with that. The two you might be interested that we haven't provided FCP in, one has recruited their own private FCP, and another is actually the largest PCN. And at the minute, I think they're having difficulty trying to work out how they spread coverage of these roles. How does it look for us? Well, each session has 3 hours of patient-facing time with 20-minute appointments, which I think is fairly common. We allow wraparound time, as I say, for the member of the staff to attend huddles, and also for those that have done the role, that important admin time at the end. I guess at this point, it's really important to note we're actually quite unsure what that optimal FCP coverage is. So our service is very much based on what we felt sustainable than any kind of national targets as such. Happy to move on again. So most conversations around FCP end up, the elephant in the room ends up being the workforce, and how are we going to staff this? Where are we going to find people from? What's that's going to cause, destabilizing in other parts of the pathway? And I think we recognised a couple of years ago that we moved probably away from a more traditional service and into more portfolio roles. So we felt that this would hopefully be more attractive for recruitment, and it has proven so, but also more importantly, retention of our current team, as they can see opportunity and chance to push themselves. Also, having that pathway exposure can only complement the complex role that is in primary care. Having those established links with secondary care can be really helpful at times. So we now have 28 FCPs across the county. We limit the number of FCP sessions in their work to 0.5. This was really based around what we were learning from other sites across the country where whole-time equivalents were facing burnout and not staying in posts. but also from GP colleagues. You know, they've moved very much towards portfolio roles for the same reason, really. Our typical job plan, we would have 0.8 clinical time with a protected 0.2 for allow them to develop themselves, but also develop the service. I think, you know, we all recognise that if we're going to go down this route, as we'll see tonight, there's lots of development, and we need to give staff time to be able to do that. Also, I think it's really important to be realistic here that FCP is not going to be the panacea to all MSK in primary care. So the role for us really does have a big education component, and by protecting this time, we're able to work with our primary care colleagues. And more recently, we've done some work with the local primary care training hub, which is really proving valuable. Thanks, Kev. So you probably don't need me to tell you much about uncertainty in COVID. Obviously, that's affected everybody in different ways. For us, it came at a time when we were about to significantly expand our FCP service in April. So that put a temporary hold on that. It actually meant we temporarily reduced some of our FCP provision. We were moving staff back into frontline services, so ED, MIUs, and also working alongside our orthopaedic consultants in the see and treat fracture clinics. I guess being able to be reactive and flexible is another benefit of this provider model, having complete system oversight. The other thing that's obviously very topical at the minute is remote consultations. So we moved almost overnight from 100% almost face-to-face service to more or less none. And I do think this was eased by some of the software in primary care, which was a lot more advanced than we saw in our secondary care. Accurex in particular, I know a lot of FCPs have found that useful, and I completely agree. But we do recognise that remote consulting just adds that further level of uncertainty that primary care provides. And I think we're currently doing a QI project looking at remote consulting in FCP, and hopefully we can learn from that. We were quite fortunate in the Southwest that we weren't quite as badly hit as the rest of the country related to COVID. So this has meant that we've been able to restart conversations with PCNs as part of the recovery plans. Obviously, there's a lot of talk around this wave of unmet need that's going to come, and we are very much seeing that already in primary care. I wouldn't say that where we are, it's directly related to patients that have had COVID, but probably more around the loneliness, the reduced activity levels, and the temporary closure of other services that COVID has brought about. Our links with secondary care, for instance, you know, we know through communications that it's unlikely we're going to see much in the way of elective orthopaedic surgery in the next 6 months. So unfortunately for these patients that are sat on waiting lists, they're going to represent, and that's most likely going to be back to primary care. So having FCPs in post, we hope we'll be able to support this. And I guess, like with most adversity comes opportunity. FCP really has a great chance now to step up and make a massive difference to our local communities. We try to adopt a population health approach, and hopefully the primary care training hub can support us with that. We've been able to embrace some of that rapid digitalisation that's happened. We're looking at virtual clinical supervision. And I've also started using apps like Pando, which for those who know is a communication medical app, a bit like WhatsApp, where you can share concerns and learning throughout the team. Last slide, so yeah, please. So I think what's important to acknowledge is that whilst this has been the Somerset way, we have very much learned from others, and what was right for us isn't necessarily going to be right for yourselves. And it's really important that whatever you develop fits your local population needs and integrates within the local pathway. I think that focus really does have to be on sustainability. You don't want to destabilise things, and I wouldn't put you off starting on a small scale as we did those years ago. I think that also it needs someone to drive it, someone to believe in it, and someone to have that sight that that this is what they believe in. We did recognise very quickly that FCP needs to be integrated from day one, and the conversations around more of looking at it from an advanced practice approach, as I know Neil and Amanda are going to talk about, as opposed to a standalone area of practice. I think another thing to acknowledge is that whether you're considering writing a SOP or you're trying to get people set up on NMP, whatever it is you're trying to do, there's someone somewhere else that's probably had that problem or overcome it. And I think I would encourage, networking, shared learning as much as possible. We've learned from others, as I say, and it's really important that you prevent time wasting when trying to reinvent the wheel. Obviously, Twitter and the future NHS platforms are good sites for this. And the last few bits, the building relationship seems like a gimme. It seems like an obvious one, but I guess for us it was really important. I think part of that was about being able to look ahead, maybe identify where we've got strong relationships, who might be able to open doors for us, but probably mostly actually identifying where our barriers are likely to be if we want to implement this. Obviously, as I've mentioned a couple of times, the local primary care training hub has been something that they've been able to offer us some training and support, and it's been really useful to work with. So finally, I guess from us is the system, our provider model really does enable a systems approach. This is an opportunity to break down that kind of historical dynamic between primary and secondary care, and we can really join up that whole pathway. And this obviously has benefits for the local health economy, but I think more importantly for our patients and the communities we serve. Thank you.
Thank you, Simon. It's good to hear some positive work in the Southwest powerhouse.
I'm sure about that.
So next up, we have so we've had a local take there from Simon, which is interesting. So we're now going to hand over to get a national perspective from Larry Koyama. So Larry is the FCP implementation lead, and he's going to take us through some of the current pitfalls and some of the current kind of topics around FCP and the effect and the influence of COVID. Larry, over to you.
Thanks, Gethin. I can't see my slides at the moment.
There we go. Okay.
No, still can't see them. Can everyone else see them?
Hold on. Technical issue here.
There we are.
There we go.
Thanks, Gethin. Those two presentations prior was really good, and I think it's really great to see Simon's example as well, which hopefully will link in quite well to some of the things that we talk about in this presentation. So the ask for me today, and I guess the remit, was really to talk about the current FCP agenda and the impact of COVID-19. So I thought it would be useful to share some of the intelligence we've had at the CSP through some surveys that we've done. So I'll talk through the survey results, and then we'll go through some of the key things that the CSP is doing going forward. Next slide, Kevin. So we'll talk about the opportunities and challenges, and then move on to this one. So this slide's fine. So we did a survey quite early on in May, just to try and get an understanding of where services were from an FCP perspective. It was only open for a few days, but we had quite a good response across all 4 countries actually. So we opened up to all 4 countries. We had some response from Scotland and Wales as well. Most of the responses we had were from NHS services. The survey itself was for MSK generically, though there were some very specific FCP questions, which is what I've taken to do this presentation. So one of the questions we asked was, what are the biggest challenges faced by your FCP services as a result of COVID? And this was really interesting, not necessarily surprising, but some really interesting things came out. One of the big things that came through as a challenge was a sudden change to digital working. And those are for a combination of reasons. So not being trained initially, a lack of equipment for services that wanted to go to digital, confidence, questions about quality. So that was a real challenge for services. It also turns out that this was also a real opportunity for services. And that raises some questions for us nationally within the CSP, but also nationally in terms of the rollout of digital solutions. Because of the impact COVID had, particularly with secondary care and some other services, there was a reduced option for treating patients in terms of options that they had. That at the same time also opened up some challenges about actually enabling patients to self-manage, and created opportunities for the CSP to collaborate with other partners to create some self-management resources, which have actually been taken up quite well. I guess further challenges included obviously people being redeployed and the impact that had, but also in some places the reduced uptake of services. But the overwhelming challenge really was the sudden change to digital platforms. So if we look at some of the comments very briefly that came up, so you can see people talked about completely changing the way we work in a short space of time, created issues around safety, governance, which had to be done very quickly. At the same time, though, it's also important to know that a lot of places did overcome these barriers, and it's important to understand what enabled some of those barriers to come down so quickly. In the top right corner, you can say working remotely posed challenges like the lack of physical examination, the loss of non-verbal communication. Patients have also been staying away from GP practices, so clinics have been quieter than usual. And there were some questions there about the quality of assessments, the implications for red flags, and so on. I won't read through every single one of them. We'll go on to the next slide, Gethin. So we also talked about how have services overcome those challenges and how they moved forward with overcoming the challenges brought on by COVID, redeployment, closure of services. And what came across really strongly again was those services that, I wouldn't say succeeded, but that were able to kind of overcome it and move forward quite quickly were ones that were able to embrace technology, but they also were able to really link in with their IT departments and work closely with relevant support. They also used that opportunity to kind of do training and engage with their teams as much as possible. So kind of keeping that team camaraderie was quite important. Also came across really strongly that networking, and this is not just within the profession, but actually externally with outside of the profession, including with primary care colleagues, was a really, really important thing for FCPs in terms of being able to go overcome some of the challenges that they were facing, and having ongoing communication with practice staff, collaboration and new ideas came across really strongly. And what was interesting is people made comments like, actually, for the first time, we've been able to just have a chat with our GP colleagues. So it's something that Simon touched on. Those conversations in the coffee room or the corridors are actually a really important part of being an effective part of that team going forward. And these are just some examples of some of those comments that came through. So working closely with our e-health IT teams to enable remote access, regular video meets, maintaining FCP service, albeit remotely, all helped to kind of maintain some of those relationships and help the service to get over the edge. At the bottom right-hand corner, lots of networking in the practice, even if just making coffee for the poor reception staff who were inundated with calls for anxious patients, looking at referral pathways within the practice. So lots of those opportunities where maybe in busier times or in times where we're, I guess, back to normal, those things may not happen, but it's really important to maintain those relationships and build those relationships as part of that core team. So these are just some more comments. We can move on to the next one, Gethin. So there's just more comments that came across around how people coped with that. So this is a slide that I like, and one that I shared a few days ago with some colleagues that were brought together at the CSP about looking at the opportunities and challenges for MSK as a whole, but FCP generally. It's based on research that's done that's looked at really high performing health systems across various countries, including examples within the UK from the Vanguard projects. And I like this slide because it talks about the kind of core things that are important in enabling services to be effective. And you can take this at a very small level, so on a micro level, looking at your team, but also you can take it from a strategic perspective in terms of how you design services going forward. And again, I think it links in really well with some of the things that Simon talked about around really having visible leadership, but also really taking that systems perspective in terms of how you design services, shared decision-making with patients and families being a really important aspect, and thinking about what opportunities have been created in COVID, during COVID, to kind of demonstrate some of these vital skills or behaviors, but also thinking about as we emerge out of COVID and we start to design services, some of the really core things that are important. Yes, excellence in practice is important, having the technology is important, but actually having effective communication, designing services to ensure that your primary care teams, that your FCPs are embedded as much as possible within primary care teams and taking into account the various the various options for recruitment, but bearing in mind that we want to have teams that are effective in delivering first contact roles, not just for that individual patient, but also the impact that has on that population of patients that you're serving, as well as the primary care team that you're part of. And the third column, second right, just talks about information as a platform for guiding improvement. And again, that touches a little bit on the importance of embracing technology, but making sure that that's evaluated and is at the right level and the right standard, but using that as a platform to share and collaborate, reduce inefficiencies in the system as we communicate between primary, community and secondary care, but also engaging patients in the design of their care where possible is a really important theme that comes across really strongly. Next one, Gethin. So the other part of my talk was to share, I guess, the national view in terms of what the CSP is doing or aiming to do to support the rollout of FCP over the next couple of years. So this is based on lots of work that's gone kind of before my time or before I started, but work that we've had to revisit during COVID and had to adapt during COVID to try and make sure that the strategy is fit for purpose, essentially. There are 4 broad themes and broad work streams for implementation. So those are national influencing. So this is the work that we have with kind of key stakeholders to maintain a commitment to roll out FCP services through national policymakers and key national stakeholders. One thing I would say is COVID has really allowed the MSK community in terms of key stakeholders to come together and have some really useful conversations. And we're making the case for the importance of FCP in that as we kind of move towards the next couple of years around the challenges MSK is going to face. We've also looked at kind of more local influencing. So that's become a really important theme. So taking some national concepts, but really working with local teams about how we support members, enable them to influence and mobilize FCPs locally. So this in practice looks like FCP and CSP regional members working really closely with NHSE and HEE regional members, as well as training hubs and primary care networks, and really looking at what's needed in those local areas to support implementation effectively. There was a key strand around mobilizing the profession. So this is about enabling our members to be able to have those conversations that are required. So very similar to some of the things that Simon talked about. So really being able to have those effective conversations with your key stakeholders, being able to identify who those key stakeholders are, being able to kind of map where services are, but also identify what the need is for FCPs and what opportunities FCPs can bring to local services. The final strand is evidence and data. So to grow the evidence base and continue working on that evidence base for FCPs across the UK, including but not limited to national evaluation. And this is quite timely because the phase 3 evaluation is soon to be out. So we've had some insights into what kind of outcomes and findings are in that, but it will probably come out in the next couple of months, hopefully, with some really key and strong themes that underpin questions like what is the actual impact of FCPs on clinicians, so clinicians being physios but also non-physios in terms of GPs. What impact does FCP have in terms of the impact on practice staff, but also on the wider system and conversations with work and health and so on. So those findings will be really valuable when they come out. All of that work is underpinned by effective comms and influencing plan. And in the next couple of weeks, you'll see some comms pieces through various channels and targeted at both physiotherapists working as FCPs, but also key decision makers. So there'll be some stuff in PCM bulletins and the NHSE primary care bulletin to try and influence those conversations and influence the people making decisions about if and how to embed FCP, because there's still a few queries around that, and we want to make sure that there is consistency in how that's rolled out. And of course, workforce is a really important issue. It's important to bear in mind that at the CSP, we take a 4 countries approach, and each country has their own slight challenges, and health is devolved. Therefore, there are some unique challenges in each of those countries as we go forward. But that is essentially the strategy for the next 2 to 3 years from the CSP's perspective. I've got one more slide. So I wanted to share this slide really, which came out of a conversation that was had 2 days ago. So we brought together about 20 senior people from all walks of life in MSK. Most of them were consultant physios, but from across the country, very much England. This is an England picture. And we asked a few questions around just, taking stock of the current pandemic, but also prior to that in terms of where MSK is and where MSK was going, but also starting to have the conversation about where does MSK need to go generally, and within that kind of bigger MSK conversation, where does FCP sit in that? So if I start at the top left-hand corner, so the purpose was really to engage across the profession, and the outcome of these expert reference groups, there'll be 2 more meetings, would be to kind of influence the future direction of where the CSP positions itself from those influencing conversations, but also to kind of prioritize and take stock of the things that we should be pushing for. We took an appreciative inquiry approach to try and understand some of the best examples, but also the real challenges being faced. We talked about the kind of key work streams, which I've just mentioned, as well as sharing some of the survey results around the opportunities around digital working. I'll be brief on this section. So if we look at this picture, what I guess the central theme here really is the leadership, systems thinking and population health came across really, really strongly. And I feel that FCPs have a really important role now, but also in the future around enabling systems to come together, and enabling MSK to start really thinking broadly about influencing the health of local populations as we go forward. And if you look at the right at the end, to where the arrow is towards the end, in terms of the big vision, FCP role is key to delivering the kind of future vision for MSK. And there was a really strong theme to say that actually we need to continue that implementation. But at the same time, we need to be conscious that there are some variations, and it's about ensuring that implementation is consistent as we go through, making sure that systems thinking and integration is maintained all the way through those conversations.
Okay, great. Thanks very much, Larry. You seem to be doing some excellent work there from a national level. It's interesting to hear that there are similar challenges that we are facing locally, across the board, across the country. So thanks for that. So next up we have Amanda Hensman-Crook. She's a consultant MSK physiotherapist and done lots of work with Health Education England. She's a Health Education England fellow, has done some pioneering work across the ACP framework. So without further ado, I'll pass you over to Amanda.
Thank you very much and good evening. So I would like to just start with giving an overview of advanced practice. I know that many of you know about advanced practice, but I never assume that everybody knows everything about it. So I like to start from the beginning and then work through that. I'm going to have a chat about supervision, and sort of set the scene ready for Neil to talk about the pathway for Neil and Tim that's going to come on in a little bit. Could we have the next slide, please, Gethin? So what is advancing practice? So there's 4 pillars of practice. You've got clinical, education, research, and leadership and management. So as you can see in this diagram, they're all overlapping. I've stopped drawing them as pillars because they can still be viewed as separate, which means that people sometimes think that you're particularly good in one of them, but or work in one thing. But what it is if you've got the 4 pillars, it influences your face-to-face decision making, as well as the local and wider workforce multi-professional working that you're doing. So it's a way of thinking to level 7 across all 4 pillars. They're not separate at all. So advanced practice is where you gain level 7 across all 4 pillars, which is a master's level of practice. Next slide, please. As you can see from this slide, this is the incremental development for advancing practice. Health education, so you've got enhanced level, which is level 6, which is degree level. Advanced level, which is level 7, which is master's level, and consultant, which is level 8, which is a PhD level. So it's a bit confusing because sometimes people get mixed up between levels and pay bands. And it just happens to be that it's just awkwardly kind of similar, but it's not the same. So with the enhanced level practitioners, what that would look like is when you've finished your university degree, then you might do a couple of years out doing your rotations in the NHS or gaining experience somewhere else within those 2 years, and then you decide to specialise in something. As you specialise, you'll be coming into the enhanced level, and then whilst you're working through the enhanced level of practice, you're building up your skill set and your skills and knowledge across all 4 pillars, and then you overlap and you gradually grow into the advanced column, and so on through to the consultant level. Next slide, please. So to be clear about where first contact roles sit, so you've had your enhanced, you're now sitting, say, in MSK, you've decided to specialise in that, and you've done 3 years or thereabouts of your training in MSK, and you've started collecting modules and you've started developing all your different attributes, skills and attributes, and you now go on to get prepared to go into first contact role. So I'm not going to talk too much about that because Neil will talk about that later. But where you sit is actually at the beginning of the advanced pathway. So the entry to when you become an FCP and you've signed off against the clinical level 7, you've not just got your clinical pillars there, you've also been pulling out domains for the other 3 pillars as well, but you haven't quite managed to top them all up to level 7 yet. So that's why you're not an advanced practitioner yet, but you're working clinically advanced to level 7. And you sit in the middle there. As you're in the middle there, what happens is when you're an FCP, you automatically now sit on the advanced practice primary care training pathway. And you can develop through a portfolio route or decide to go through a master's course to advanced practice, which is level 7 across all 4 pillars. Next slide, please. So the governance is something that we've been looking at around first contact really closely, because as you know, there's already existing first contact practitioners in the system, and some of them may have been less experienced than they maybe should be sitting in the posts. And the GPs, because they're a business, they will employ who they want to employ in primary care currently. So we needed to think about a way that we could try and monitor this to make sure that the right person's in the job with the right capability levels so that it's safe for the patients. So the people that we're really closely working with are the CQC and the HCPC. The HCPC are busy doing a review of their standards, and they've set up an advanced clinical practice part of it that's very specific, that they've just started doing the review now. So we're working really closely with them with the pathway that we have developed from developing into FCP and from FCP to advanced practice. So working closely with them so that they're very aware of where the core capabilities are and the speciality capabilities are, so that they will be able to govern it from a referral point of view. So if you get referred to the HCPC for bad practice, they will have something to sit against to know whether or not that you've been working within your capability level or not within your competency level. Also, CQC are externally going to be monitoring this, which is another reason why it was really important to build a pathway that had standards and capabilities and competencies attached to it, because they want something physical to be able to look at, so that when they go around and review GP practices and PCNs, they'll be able to request to see that that person's got a portfolio of evidence to say that they're actually working at the level of practice that they are, and that they're working within their scope of practice. And again, that boils simply down to patient safety, and it also protects the physiotherapist as well, because, like I said, it's a business. So there's often a way where the GPs might try and push you outside your scope of practice because they can, but then you've got some actually, this is my capability set, and it will be monitored by the HCPC and the CQC. And the most important part of governance is around supervision. So next slide. I think we're frozen, Gethin.
Hello. You got me?
That's it. Sorry. Yeah. Sorry. I think it's my internet. It's in Cumbria. It's a bit dodgy. Sorry, guys. So this is the pathway that's been passed. This is the official copy of the MSK First Contact Practitioner pathway. So the first part of the diagram that you see, I'm not going to go into this. I'm going to say high level because Neil's going to explain this properly. So the first part of the diagram is how to become a first contact practitioner, and then there's 3 ways that you can do it: through a portfolio route, or through a blended route, or by a taught route. And then they're on the MSK CP pathway. So hot off the press today, what will happen at that point is that you will be going on to the advanced practice training pathway for primary care. So once you've got your ticket, whichever way you've got it, to be a first contact practitioner, you'll then be able to become on a first contact practitioner directory at the Centre of Advancing Practice, which means you're then officially on the route to advanced practice. So the second part of it is how to become an advanced practitioner from being a first contact practitioner. And again, there's 3 routes to do that, which again, Neil's going to talk about. But if you look at something like that, you can see that there's many areas in there that, well, the whole lot needs to be properly governed, because it can't be a tick box exercise. It's not possible to do that, because you need to assure the system and the patients that you're working at the right level of practice, and that you're capable and fit to do the job role. And really importantly, you know how to work in primary care. There's a massive difference, and I'm sure that anyone will allude to it that's become a first contact practitioner. There's a really big difference from working in a community or an acute trust to working in primary care, where you're suddenly thrown into a different environment completely. So the primary care training is really core to all of the pathways that you can get to be an FCP. Next slide, please. So the supervision, it's important to understand supervision. It's really divided into clinical supervision and CPD and education supervision. So it kind of all gets lumped together, and it gets called mentorship and everything. And as you've probably already noticed sort of out there in the ether, that terminology is a real problem. So to be really clear, there's 2 really important parts of supervision, and even though they come together in a way, they are very separate. So clinical supervision is your day-to-day caseload supervision in the workplace. So that's anything that goes on with your day-to-day work. You need a named supervisor within the GP practice that will look after you with that. So that's in-house governance. And then you've got your CPD supervision, which is for your personal development and well-being, and they're the supervisors that can take you along and guide you through a portfolio route to FCP, and then again from FCP through to advanced practice. And this, at the end of the day, it's all about providing governance to keep you safe, the patients safe, and to maintain equality within the system. Next slide, please. So what we're doing at the moment is we're developing a supervision support system in primary care. The most important thing, see, around the country, there's already some advanced practice primary care forums, which we're looking to develop across the whole country. They're led by an advanced practitioner, and the forums they're like a peer group support, and for advanced practice, and that's multi-professional, so that you can cross-fertilise all your ideas with all the advanced practitioners out there, because of course if you're an advanced practitioner, it is multi-professional, cross-boundary working, and it links in to all of the clinical settings. So it's not just about primary care, the primary care forums, it's about inviting all the other sectors into that hub as well, to make sure that everybody's communicating properly with each other. And then you've got the training hubs, and in the training hubs we've put some money in to develop advanced practice clinical supervisors. So it's a 2-day training course, and how to do the clinical supervision will be part of it, and how to do the CPD supervision as well. The CPD supervision will be very specifically tailored to help people take people through the portfolio route, so that they can support them to identify their areas of need through the training, and also they'll be trained up to know how to link it to all of the different capabilities. So initially, the trainees will come from the primary care forum. So the only people that will be trained up will be people that already sit in advanced practice positions, i.e. signed off against all 4 pillars. And that again is to do with quality assurance. This is all linked to the primary care schools, and the primary care schools will be taking on an awful lot more work from the training hubs. They're going to become more and more important as the years go by. And the primary care training schools have a direct link to the Centre of Advancing Practice at Health Education England. So the supervisors that are trained up through this system will have a rubber stamp on them, and they'll be credentialed, and they will be held on a directory at the Centre of Advancing Practice. And that's quite significant because it means that it then opens the doors for more remote supervision training. So people, say if you lived in the Outer Hebrides, for example, and you may not have any advanced practitioners up there, it means that they'll be able to link to the Centre of Advancing Practice and be able to find a supervisor to help them through the portfolio route and to support them with their CPD supervision. I don't know if that's the last slide, is it, or is it? I think it might be, Gethin.
Yeah, that's it.
Thank you. So
Okay.
I'm not going to talk too much about it. I think Neil's going to go on and talk about the routes.
Yes, we'll get Neil in a second. Thanks, Amanda. There's some good updated guidance there on the supervisors and supervision, so thanks for that. Next up, if Neil is still with us, he's got the graveyard shift, unfortunately. Okay. Yeah, so next up we have Neil Langridge, who is a consultant MSK physiotherapist and a honorary fellow to the MACP, and I believe a co-opted education lead for the MACP as well.
Thank
Neil,
you.
over to you.
Yeah, thanks for the invitation. Thank you, Gethin. On the back of the presentations we've just seen, going to just try to pull together the relationship between FCP and advanced practice in terms of pathways and how that might relate to career development. I think one of the most exciting things that I've seen being part of what we've been doing is the opportunities to create a career pathway that A, is clear, and B, gives structure, and C, really importantly, that you can ensure that your professional development, your opportunities for learning have some sort of structure to them, and you can see the value in each of those experiences that you have. So I'm going to try and bring those pathways together you've had explained to you into some sort of structure that is still an iterative process. We're still pulling it together and tightening things up. But hopefully I'll be able to summarize the earlier sessions. Next slide, please. So the AP pathway, you have a standard higher education institution, MSc, so level 7, as you had that explained, mapping to all 4 pillars of the advanced practice framework. So these individuals have demonstrated level 7 capability across clinical practice, education, leadership, and research. And that then takes them into the Centre of Advanced Practice, and they become on the Centre of Advanced Practice register. Okay. Through the non-HEI model, you have an opportunity to work through a MSK portfolio route. That has 2 options currently available to you. The Advanced Practice Register and HEE developing a portal through the Centre of Advanced Practice, which you'll be able to upload evidence and have that signed off. But you would require a mentor to be able to do that for you, and that a portfolio would get assessed by the Centre of Advanced Practice, and either recommendations would come back for some alterations or some resubmissions, or you'd be added to the register. The other option that we are exploring significantly through the MACP is an already established, as many of you may know, portfolio route, so a self-directed option towards MACP membership. That is effectively a level 7 sign-off of evidence that's submitted to the MACP, and we're in discussions with HEE to have that route accredited. So once you complete your portfolio route through the MACP as a learning partner, offering you support through mentorship, educational material, you would then have the direct relationship with HEE to put your submission directly onto the Centre of Advanced Practice. And of course, as mentioned, there will be an option as a blended route where you take the opportunities that you've had, whether that's MSc modules in previous times, and opportunities around portfolio submissions, and you blend that evidence together. You can blend it off through the HEE portal, you can blend it through the MACP portfolio route, you could blend it through previous MSc credit points, which ultimately, when you build it together, again, will take you to the Centre of Advanced Practice as an advanced practitioner. So the key here is that there are options available to suit individuals dependent on the position they are in their career, and obviously lifestyle choices as well. Next slide, please. So as mentioned, the MACP involvement has been very important in terms of involvement in the mapping work that has mapped the multi-professional advanced practice framework to the IFOMP standards, the leadership around the MSK partnership, and the agreement of those standards across multi-professions and intra-professionally. The MACP has, as you know, accredited MSc pathways to MACP membership and are strengthening the portfolio routes. And of course, as I mentioned, they are self-directed based on the same standards, but with differing methods of evidence retrieval. With the portfolio route, recently we've been able to pull together a governance framework that allows what we're describing as an accelerated route to membership. This would be for individuals that have the capacity to easily demonstrate high-level level 7 and likely above in the 4 pillars through a professional portfolio, and they will go through a process that will accelerate them to MACP membership. And as mentioned, we are strengthening the standard portfolio route. We're reviewing the governance process and looking at the process and logistics to ensure that we are an effective learning partner towards anyone working with the MACP and linking to Health Education England. Next slide. So when we're talking about the governance around advanced practice, it is really important, most importantly for patients, that there's assurances in the quality assurance around our practice, but it's also important for stakeholders and, of course, yourselves as clinicians. So effectively, a portfolio route governance process has the mentorship sign-off. So that individual will have the supervision standards. They will be a level 7 clinician, and they will sign you off against the portfolio requirements towards advanced practice and MACP membership. That will then be reviewed by a panel with potential HEI or certainly HEI level sign-off. And as mentioned by Helen earlier, you have the external examination process giving the assessment towards IFOMP standards, which gives us a further quality assurance. We're working closely with Health Education England to recognise that standard towards the Centre of Advanced Practice. Next slide, please. So how does it link to a primary care FCP pathway? We've had the MSCs in musculoskeletal practice for some time. We're now going to see that musculoskeletal standards of practice applied across Health Education England. And we now have many FCPs, and certainly for the future, for musculoskeletal practice, as Larry was saying, primary care MSK practice is vitally important. So these are the routes that some individuals will be able to take themselves through towards primary care FCP. So in the first example, this may be somebody who's already completed a level 7 master's degree. So they have the 4 pillars of advanced practice. They've had it signed off as a musculoskeletal clinician. However, they still haven't been able to demonstrate the primary care skills and knowledge required. So they still will need to go through a sign-off process because of the relative differences between primary and secondary care. So to do this, they'll go through a standard set of primary care digital skills and that they'll be able to access through Health Education England. They then will have their evaluation of capability in practice through a similar portfolio model. They will be assessed in practice by an appropriate supervisor, which they will take them through to, as well as being an advanced practitioner, they will also be a first contact practitioner with the appropriate skills and knowledge demonstrated. The further pathways are for individuals not on who's not completed an advanced practice route. So they will be individuals that are greater than 3 years greater post-registration experience, and they effectively have taken themselves through the clinical pillar of the advanced practice route. So just as a reminder that first contact work is not, in the clinical sense, is at level 7, but still there are some gaps in education, leadership and research, which can be facilitated through an application through the advanced practice pathway at a parallel time, and I'll come to that in a second. So these individuals, your options, if you want to become an FCP, you could complete a master's level module in first contact practitioner work that is mapped to the MSK core capabilities framework, and again has the appropriate digital sign-offs through the e-learning for health, has an appropriate evaluation in practice, and that will lead you to an FCP accreditation. Once again, we're looking for options for individuals. So an FCP portfolio route, which allows an individual to use evidence from their practice to demonstrate the knowledge, skills and attributes of a level 7 clinical practitioner in first contact work. Once again, they will complete the digital skills and requirements. There will be an expectation of these individuals to have completed their MSK sign-off. So when we get an individual wanting to go into primary care work, we would expect them, before they enter the threshold of primary care, that they have had a selection of their MSK knowledge, skills and attributes that defines them as a level 7 practitioner within that clinical pillar signed off. And this piece of work has just really come to an end, and we will be ready to publish that and share more widely. So those individuals would have completed their e-learning, they would have completed their early MSK level 7 sign-off, and then they would complete an evaluation in practice to complete their primary care sign-offs. And that again would lead them to an FCP accreditation. So what you see there is 3 separate routes: individuals already at AP and individuals wishing to work as a first contact practitioner, either through a formal MSc module route or through a portfolio route that allows the final sign-off through the primary care training hubs. Next slide, please. So just as a reminder, we have the MSK FCP AP route, the MSK MSc module, and as well as the MSK portfolio route, and of course the last two routes can be as part of a blended role and support route if required. Next slide, please. So importantly, we want to be able to link those experiences you have, whether you're on an advanced practice pathway or you're starting out as a first contact practitioner. So as a clinician, you might identify as part of the career modelling that you wish to engage as on the first contact and AP pathway. Through the first contact competency document that I alluded to earlier, there are clear reference points to when you complete a piece of evidence and you submit that piece of evidence. Not only will it map to the MSK core capabilities framework, it will also give you reference points that mapped it to the advanced practice pathway as part of the IFOM guidance. Now, again, it would be very, very sensible for that individual to take their evidence and use it across FCP and advanced practice pathways. One way they can do that is through special interest groups, such as the MACP, offering a recognised route to build the evidence as a learning partner, or use evidence as part of a blended or HEI route as a potential recognition of prior learning. So you may take your first contact evidence, and certain universities may offer recognition of prior learning as part of the evidence base towards an advanced practice MSc. As you complete your first contact sign-off, you've completed a large majority of the clinical sign-off for AP, and you'll be able to reference that experience onto the AP pathway and continue to build your education, leadership and research level 7 capabilities, either through an HEI or blended model, to effectively take yourself through to advanced practice with a sign-off in primary care. Next slide, please. So this slide just gives you a sense of building in your clinical experience, really from the first point of career pathway. So even as a band 5 starting out in clinical practice, any CPD that you wish to do, that you get involved in or you apply for, you will have reference points within the first contact pathways and the advanced practice pathways to set the agenda around what you would wish to do on a year-by-year basis. And you'll be able to reference and evidence those experiences against those pathways. Now, of course, in the early stages of your career, you may not be able to reference it all at level 7, because this is master's level practice. But of course, there may be elements of your career experiences that you rapidly pulled into a level 7 sign-off. That requires mentorship and that requires the supervision. And therefore, you will build your pathway from that first point of your career right up to level 7 first contact and advanced practice pathways. And certainly, if I reflect on my career, this would have been an absolutely ideal way to map my own career, when as times have gone on, we found that continually difficult to do because the frameworks haven't been available. And as they have emerged across the 4 nations, we're seeing significant changes, as you're experiencing here, around what pathways may offer and how they may link to CPD within your own workplace, but also across the national picture. So as if you build your CPD, you link that to your FCP pathway, you link that across to your advanced practice pathway, and when ready, and when the consultant framework is published, you'll be able to see how those pieces of evidence will map towards a consultant level framework, which, as mentioned, is doctoral level at level 8. So what we would hope to see is a career option for musculoskeletal clinicians from band 5 right up to level band 8 and above, with appropriate navigation points to level 7 in FCP, AP, and level 8 in consultant practice. Next slide, please. A piece of work that we will need to complete on at the very end, as these frameworks become more public and are fully signed off, is what we're describing as a roadmap, a supportive roadmap that basically navigates the pillars and navigates the individual across those pillars into FCP and AP. So somewhat like the presentations you've had today, putting them into a document that will allow you a supportive guidance about helping you make decisions about your own careers. It will have resources, and the CSP will be contributing to these and in part of their development work towards career modelling in terms of the FCP and AP pathways. So effectively, from band 5 upwards, CPD used in multiple ways, but most importantly, in integrated ways across both pathways. Thank you.
Okay, thanks very much, Neil. I know it's an often complex journey and understanding of some of the competencies around ACP and FCP, but hopefully this some clarity on that. Okay, so we'll hopefully now just hand over to some of our delegates. We've got some questions lined up from some of the Facebook feed. So let's just unmute everyone. Okay, is everybody here? Okay. So who I haven't introduced is Tim Noblet. Sorry, Tim, left you there. So Tim's involved in the FCP work. Do you want to briefly describe what your project is at the moment, Tim?
I've been working more on the FCP, kind of the standards, knowledge, skills and attributes that people will need from an MSK point of view to be able to enter into the training pathway to be an FCP and onwards towards advanced practice. So kind of the governance around the actual skills and the knowledge people will need to be able to go into that line of work.
Okay, great. So let's go ahead with some of the questions. We have one from one of the audience, which is a fairly straightforward one, I think, to start with. This is from Oliver Sell. So should Band 7s be working in FCP?
Should Band 7s be working in FCP? Is that the question? Sorry, my internet's choppy.
Yes, it is, Amanda.
Yeah, okay. Well, yes, they should be Band 7 to be working FCP. So it's more about your clinical capability. To be level 7, and if you've got a clinical capability at level 7 at FCP level, then you should be a band 7. They shouldn't be working below band 7 in primary care. Let's put it that way around. So if you're band 7 that's working elsewhere, then absolutely why not work in primary care?
Good. We have a question here from I think somebody in the Southwest. So maybe this is one directed assignment. So what are the opportunities locally in the Southwest for physios keen to progress to become first contact practitioners?
Well, I think it depends on where they are in their progress, I guess. But obviously, locally, explore what contact with the primary care training hub, see what opportunities they can provide. But also, there's potential for an FCP module coming out here at Plymouth University, which a number of us clinically, yourselves, Gethin, North Devon, are feeding into. So that's the one certainly to watch this space.
Okay, good stuff. We have, this is another one from the Southwest. So somebody's asking, how does the panel feel implementing the up-and-coming frameworks will be seen in everyday clinical practice? So how easy would it be to implement in everyday clinical practice, and potentially what are the barriers and how would we overcome those barriers?
Do you want to go, Neil?
Yeah, I can't say. It's probably something I didn't really touch on. From the FCP perspective, Tim's work has, as mentioned, has really built in the requirements, so the skills, knowledge and attributes to embark into primary care. So it'll be very clear what skills you need before you even start. We've got the e-learning for health, and there's a number of e-learning for health modules. They'll be run around complex clinical reasoning. We have primary care e-learning and personalized care that will help ready those individuals, but again, map against the frameworks. And whilst you get into primary care, we've been fortunate enough to be able to use the RCGP portal for uploading evidence in the same way that a GP would. So in terms of, again, the implementation of the framework, I think we will have appropriate documentation to help those individuals. The supervision work that Amanda's team is putting together will give you the individual that will help take you through those frameworks. So we have operationalized, I think, the frameworks that are out there to allow those individuals to be well supported in the same way that a GP would, going through their GP training work.
I think another thing that's important to say around that is that even if you are an established, 15 years into advanced practice and you're thinking, oh, actually, I'd quite like to work in primary care, or already working in primary care, to go through this framework, it's not too arduous if you're already there. So that you will be doing your CPD and clinical supervision, as we all do or should be doing anyway. It's just a case of collating the evidence and putting it onto the digital portfolio so that it can be signed off. So I think if you're an established advanced practitioner or above, or a consultant, to go out and go through this process, for you could do it lazily, easily within a year, and it wouldn't be any additional work for you to do. If you wanted to be quick at it, you could do it in 3 months, 4 months. So I think it's really important people don't see this as another hurdle, because I think a lot of us out there, every time we've moved jobs, have to go through the hurdles again. Some of us have done it 3 or 4 or 5 times, and it shouldn't be seen as another barrier to practice. It should just be seen as ongoing CPD, which keeps you up to date and fresh and keeps it interesting.
Yeah, thanks, Tim. Good point. We have a question here regarding, so with the IFOM standards mapped against the MSK-ACP framework, will existing MACP members in advanced practice roles require going through the credentialing process for the ACP register?
That's something that we're looking at from an MACP, working with the wider MACP partnership and looking at the AP standard documentation. There is an expectation that all physios are required to meet HCPC standards of education. We sign up when we re-register as physiotherapists. So there might be an element of grandfathering across if that the MACP member has kept up to date with their clinical education and CPD activities in line with HCP standards.
Okay.
I don't know.
I mean, that leads on. Sorry, go on. Neil? No.
I think that we're very much, the plan is that if you're an MACP member and you've met the IFOM standards, that therefore we would be looking to grandfather those individuals into those roles, onto the Centre of Advanced Practice. And it's also really important, as the point that Tim made, that we really want those individuals to get involved in primary care because they've got those advanced MSK skills, and get those individuals as well as onto the Centre of Advanced Practice register, to get them also on the FCP register as well.
Okay, great. I mean, that leads on nicely. There's a question from Emma here, Emma Julian. So she's got an MSc and is a member of the MACP, but works for a private health company. How does she start the move into FCP training role from a non-NHS role?
In just the same way as everybody else, in short. If you're an individual, you can be guided, and the APPN are going to be setting something up to help individual practitioners to be able to go through to help supervise them, to support them to go through the portfolio route to FCP. And I'm sure that the MACP and SOM will be welcoming people to them as well to help support them. But once you're in primary care as an individual, you will be supported through the portfolio route to AP anyway via the by the portfolio route pathway that's in the training hubs.
Okay, great. And we've got a question here on kind of timelines. I know that Amanda touched on the new supervising or the supervisor guidance, and Neil touched on some of the work around the FCP competencies. What are the kind of time scales? There's lots of questions on the time scales of these.
Yeah, I'm sure there is. There always is.
So can anyone shed any light on that? Or?
No, I've spent all day talking about that. So in terms of the clinical sign-off, that's almost good to go. So Tim and Jodie have produced an absolutely fantastic document, and the team have had a look at it this week, and we're all really, really happy with it. I've taken it to Bev, who's had a look at it. She's happy that that's looking good. I just need to send it to Richard Collier to rub a stamp to say that he's really happy with it, but I can't see how he won't be, because it's all the it's all the framework in the middle of it, of the document. So so it's really good to go. So once it's a working document, we can get it out to people to start running through it. It's more around making sure that we've got the suitable clinical supervisors to take people through the route. You will need to be an advanced practitioner or be working at clinical level 7 to be able to help people through this portfolio route. In terms of the supervision trainers, we're just finalising the strategy behind that. But again, that's an imminent thing. It's not something that's going to be several months away at all. I would think that that should be up and running by the autumn at the latest.
Gethin, there's another piece of work that Amanda and myself are chairing, which is taking the IFON standards and putting them into the language of the pillars of advanced practice to make a multi-professional document which will support the AP MSK standard development, and looking at the clinical governance around professional network and special interest groups, having that learning partnership that Neil talked about, and making sure that the clinical governance overarches all those routes into AP accreditation. And Neil and Tim are our project leads on that piece of work. We've set them an ambitious timeline of hoping to have something out by the end of August, September, because we really want to engage with our HEI colleagues to make sure that when we're launching this comprehensive framework, that those routes to AP accreditation are well established, and that everybody knows that end point and that finish line that they want to get people across to get on the AP registry.
Okay, good stuff. Excellent. We've got a few questions on some of the differences around the kind of models of FCP, so the in-house kind of standalone FCP versus the secondary care trust or the integrated model, and some of the challenges around that. So some of the people are asking, or some of the viewers are asking, how do we manage the different provision or referral into the same service from each of these strands? So I guess from a service integrated model versus a standalone practitioner, and potentially other kind of areas that have private healthcare systems with a slightly kind of fragmented healthcare system. I mean, how can we ensure that the PCMs are standardized, and also some of the quality of the referral pathways and the referrals are standardized?
Well, firstly, the PCNs, if they're going to employ those individuals, are going to have to meet the same standards as everybody else. So by going through the same process, you would hope that you assume that the quality of referrals are going to be the same, whether you've employed that individual or they're working an integrated pathway. I can only talk from our experiences, and Simon will be able to, I'm sure, add to this, that PCNs, I think if there's a good offer from a local integrated MSK pathway, in terms of education, governance and leadership for these practitioners, they are very interested in the main in handing that over through some sort of contract. So we're certainly, as in our organisation, building an offer to PCNs with a leadership 8A role, with Band 7 clinical practitioners as part of the offer, and we will then support those individuals through their governance and their clinical sign-off. So effectively, they get these practitioners, the funding comes through them into us, we'll recruit them, but they'll be part of the integrated service, which again, for the service user and the population, means that you really do smooth the pathway out as much as possible.
Yeah, I think just building on what Neil said, I think the governance is one of the big selling points from PCN perspective. The one PCN that has taken on a private practitioner in our region, we have actually been approached by the CCG about whether we could support that governance. Obviously, that's very difficult. with them not being a member of staff and not gone through our capability framework, etc. So I guess you'd want to join it up as best you can, so you don't have a fragmented service within your locality, but there are obviously restrictions around governance in that.
Okay, great. We have an interesting question here from Chris, playing devil's advocate. So he said he's not advocating this, but playing devil's advocate, can any clinician just apply for an FCP role via a PCN with no potential MACP link? What do you think of the risks are to this, i.e. you don't technically have to be signed off AP to do the role?
Well, that's not actually true. So at the moment it's true, but there's a bit of a double whammy here. So hopefully in the next DES, the pathway is going to be in it, and you'll have to turn up at the interview with your signed piece of paper to say that you're you've done the FCP sign off, whichever route it is, and hopefully there will be up and running. Well, there will be. There's going to be an FCP register, a directory, sorry, at the Centre of Advancing Practice, so that we know that you've done your sign off, so that the employer can actually see that you're on there. We have got the CQC on board, we've got the HCPC on board, and also that means that everybody, this is a bit of the elephant in the room really, but everybody, because there's never been a standard of practice before in primary care, because you're absolutely right, at the moment anyone can walk off the street into jobs because they're a business, that's how it works. However, once this is all gone through and it's all tied up at the end, everybody who's currently in practice that has not been through the pathway will need to sign themselves off against the portfolio route. So that if you're an FCP, you will need to work through that with a supervisor. Like Tim said, it's not arduous, you just do it as clinical supervision, which we should be doing anyway. And if you're an advanced practitioner sitting in these roles, in the advanced practice roles, then you will need to sign off against all 4 pillars and have that portfolio of evidence as well for when the CQC comes to inspect the practices.
And in the timeline to that, Amanda, potentially August, September, is that right?
Well, you see,
I'm not going to hold you to that.
Moving feast, you see, at the moment. So what I will say is that in the next DES write-up will be out in March next year. So I would recommend to everybody to start going on the clinical sign-off route now, ready for those roles for next March. For those that are already in post, once the clinical sign-off has happened, I recommend that you start using that as a useful template for to guide your CPD through being supervised with your supervisor, as you would do normally in an everyday thing. It just means that you've got something that's a bit more structured that you can work against.
And I suppose to add to that as well, there is obviously that piece of work coming along, which is really important. I think that question was a really good question, by the way, because in the current context, those things are happening, and there is a role for all of us in how we engage with our stakeholders. So me and Amanda have worked really closely on a bunch of JDs recently that we're trying to get out to the system to make sure there's that consistency when people are making decisions. So there's the onus obviously on the clinicians, but there's also that onus on the decision makers within the system to really think about and support a consistent approach to implementation. Okay, excellent. Well, I think we'll wrap it up there. We've had some good questions, and everyone can just get back to their evening now. So thanks very much for all the panelists. We've had some good discussion on the Facebook feed, and we've had some new interesting kind of guidance updated from all the team. So thanks very much for giving up your evening, and thanks very much from the Southwest. Bye. Great job, Gethin.
Thank you.
Well, thanks, Jeff.
Yes.
Bye now.
Bye.